Hello, everyone, and welcome to Africa Fire Mission's weekly virtual training session. My name's Mike. I'm a project coordinator with Africa Fire Mission. I'm so happy that all of you took time out of your busy schedules to join us today for today's training. Today we have with us Dr. Evie Marcolini. She's got a lot of great lessons to bring in emergency medicine that she's going to discuss a little bit later on today. If you stick around with us for at least 70% of our training, 45 minutes of today's training, you'll receive a certificate of attendance for today's training. Be sure to set your name to whatever you'd like to appear on your certificate there. Keep your eye in the chat, as I'll put some information in there where you can get to our Google Drive and you can attend today's class or any classes that we've had earlier in the year and receive a certificate of attendance for those as well. I'd like you to join us afterwards. We're going to have tea time hosted by Jose, AFM's fire safety advocate. Before we get started with today's training, I'm going to pass it over to Richard for today's words of encouragement. Take it away, Richard. You're muted, brother. Oh, I can't. That's my fault. There you go.
Yeah. Thank you so much, guys, for coming over. Every firefighter has to get this opportunity to learn today. You're much welcome for joining us. Today I want us to have a very small word of encouragement about humility. If we check on the dictionary, humility is a quality of being just humble. Humble being like you're not always on everyone else's neck. You don't go up, down, like you told to do something, asking a lot of questions that sometimes are not relevant, asking about other people, minding other people's behaviors, like personal lives. That one we try to discourage it. And also the Bible tells us in James 4:7 says, therefore, it says, God opposes the proud, but gives grace to the humble. Today, I wanted us to reflect on our fire station. How do we take it when someone corrects us? How do we take when someone comes and tells us, no, this one is not what we're supposed to do in the fire station, we're supposed to do it out of the fire station. Or this one is not what a firefighter should carry themselves, even when on duty, while off duty. How do we take that? Are we the same people who always shout? Are we people who always start condemning them and calling them names or start cursing them? Also, in our workplaces, we have bosses, we have fire chiefs, we have duty officers, the person who is the immediate person who is taking care of that particular shift. When they collect, either in scene of fire, in the office, how humble are we? How do we take? So mine is to challenge ourselves, even at home. We have family, we have brothers, we have sisters, we have wives, and we have husbands in our homes. How do we take it when they correct us? Our sons, our daughters, how do we take it when they correct us? Because remember one thing, every day is a learning day, and every day we always have something to learn. That is one that's a virtue that each one of us should be able to hold in their mind. And for that, we can have a short word of prayer as we start the lesson. Thank you, our dear Heavenly Father. We come before you this evening, God, with thanksgiving and praises in our mouths and in our hearts. We pray that as we start this lesson, may you open our minds, our souls, our thoughts, and everything, Jehovah, so that we can understand what we are going to learn today. Bless every firefighter in our country, outside, and the entire world as well. Bless the firefighters who are in the US. Bless our instructor today. May you give her the knowledge and power to share the best knowledge to us, Jehovah, and the knowledge that we'll get. May you give us the power and the understanding Jehovah, so that we can be able to replicate the same that we're going to be taught to here today to the other generations of the firetakers. And in Jesus' name, we do pray and believe. Amen. Thank you and be blessed.
Amen. Thank you. Thank you very much, Richard. We appreciate you joining us today and sharing those words of encouragement. At this time, we're going to jump into our training. I encourage you, if you have any questions throughout the training, you can put your questions in the chat. We'll be monitoring that. We'll also have some time available at the conclusion of our training to ask any questions as well. So please feel free to either raise your hand or put your questions in the chat as we're going along. At this point in time, we're going to pass it off to our instructor of the day. Take it away, Doc.
Okay, thank you. Thank you very much for having me. Can you all see my slides?
Yep, we're all good.
All right. I want to reiterate, if you have questions while I'm giving this talk and going through these slides, please put them in the chat and we can stop and take a question here and there. My name is Evie Marcolini. I'm an emergency physician and a neurointensivist, and I work at the Dartmouth Hitchcock Medical Center. And here's a picture of my medical center on the top left corner. Mike, can you see my arrow when I'm using this? Yeah, oh,
yes,
good.
we can.
All right, great. But before I became a physician, I was a paramedic and I worked at the Wyndham Fire and Rescue. And as I was working there, the town changed their parameters, and they asked every paramedic to become a firefighter. So I did go through the firefighter training and I was on call as a firefighter. I will say I never had to run into a burning building. But I have a high respect for those of you who do. And I think it's a job that is just so important and so just important to your community, important to lives and people. And I just want to thank you for what you do. And then in the bottom left corner is what I do in my free time, is going for hikes with my 2 dogs. And you all, I think, heard from my husband, Paul, last week, and he showed you where we live. And I want to just review first some of the patient assessment system that he went through last week to put us in a place where we're looking at the critical systems. So you learned about how to assess the patient. Now we're going to dig deeper and look at the circulatory, the respiratory, and the nervous system. And we're going to talk about, how do you assess your patient? How do you figure out what's going on? So to start off with, here's a slide from last week. Remember, you get to the scene, you stabilize the scene, making sure everything is safe before you jump right in to grab a patient and start taking care of them. Then when the scene is safe and you have your patient, you do a primary assessment. That's where you find the life-threatening problems. And after that, you'll do a secondary assessment to find all the other problems that are going on and to find more clues as to what's really going on with this patient. So let's hone down on that primary assessment and talk about the 3 systems where you will find life-threatening problems. That's the circulatory, the respiratory, and the nervous. And I'm going to give you a case. You're working at a fire, you go to the back of the building, and you see a person who's down on the ground. And when you get there, you've already assessed for scene safety, and your primary assessment reveals that the patient has a rapid heart rate and rapid breathing. He is A on the AVPU, and we'll review what that means as well. But he's complaining of chest pain and abdominal pain. So let's start with the circulatory system. The circulatory system consists of 3 components: the heart, the blood vessels, and the blood that flows within it. With the heart, we're talking about, can that heart squeeze? That's a muscle that has to squeeze the blood through the system, and it has to be strong enough to do the job. The vessels are the vasculature that hold the fluid. And you know, if you have somebody who's bleeding, then you have a ruptured vessel somehow, and the blood is the volume. Without enough volume, you're not going to get that pump to work. If the vascular system isn't intact, it's not going to get the blood back to the heart. So I like to break these things down into very simple, straightforward assessment, because when you get to the scene of somebody who's down, the tendency is to forget all of the medicine that you ever learned and to focus on the stress of what's going on. And I like to break it down so that when we're under stress, evaluating a patient, we can get simple and remember the basics. So in the circulatory system, we're talking about a problem called shock. Shock can exist if the heart is not pumping strong enough, if the blood vessels are not intact, or if there's less blood volume. So let's go through this. With poor cardiac output, that can be because the patient's having a heart attack, or it can be some kind of an arrhythmia like a ventricular fibrillation, something like that. That's called cardiogenic shock. With vascular shock, we think of poor vascular tone. What that means is that the blood vessels are dilated. If you think about it, if those blood vessels get bigger and you have the same amount of blood within the system, now you don't have enough blood to get to the heart. And then that's vascular shock, something such as anaphylaxis. If you have low blood volume, if your patient is bleeding externally or internally, they can have volume shock. So back to our patient. You find him, you assess the scene safety, you got his history, now you're examining him. And when you take off his gear, you find that he has a distended abdomen and it's very tense. So we're thinking about volume shock. We're thinking about whether or not this patient is bleeding. You have probably examined him externally, both on the above and below. If he's lying on his back, you're gonna turn him or look underneath to see if there's any blood. You're looking for external bleeding. But now you found that his abdomen is distended and tense. So you're worried about internal bleeding. And I want to review this volume shock pattern. This is an important concept to think about with patients who are bleeding. When a patient is bleeding, and let's talk about this patient who probably has an internal bleed, maybe he has a ruptured spleen or something. The blood volume is going down over time. He's losing volume. Now, if this was an external bleed, you're going to put direct pressure and you're going to stop that bleed. And you'll probably fix the problem right then and there. But if it's an internal bleed, you're not able to fix it unless you get that patient to a hospital. So as the blood volume goes down, we will also notice skin perfusion decreases. That's when somebody's skin becomes dusky or clammy or sweaty. And if we were looking at urine output over a long period of time, we might notice that that goes down as well because the kidneys aren't getting perfusion. At the same time, the heart rate goes up, pulse rate goes up, and respirations go up. They're going up because they're trying to maintain blood pressure. So if your heart rate and respiratory rate goes up adequately while the blood volume is going down, you can maintain blood pressure. That's the body taking care of itself. When the blood pressure is okay, the mental status is okay. But at a certain point, if you don't stop the bleed, they're going to lose enough volume that the heart rate won't be able to compensate. And then the blood pressure drops off, and then the mental status drops off. So here's your patient who has internal bleed, you suspect, and you're trying to figure out what's going on. You're going to get him to the hospital if you can, but if not, you want to monitor him and understand what's happening. If you see the heart rate go up and up and up and up, and he still has good mental status, that's okay. But if you see the heart rate going up and then the mental status decompensates, now you're worried. This is a critically ill patient. And when I say that, I know that we may not have a blood pressure cuff. We may not have a cardiac monitor. We may not have any tools. What we have is the best thing we have is the examination that we do and the mental status. By talking with your patient and understanding their mental status, you'll be able to tell if they're hanging on, if they're maintaining, or if they're declining. And that's going to help you determine how fast do I need to work to get this patient to a hospital. So this is an important concept, the volume shock pattern. If blood volume is decreasing, heart rate is going to go up, blood pressure will maintain until it doesn't. And the most important thing to watch is the mental status. Well, that patient told you, let's have a different scenario. What if that patient had a perfectly normal exam? You didn't find any evidence of internal or external bleeding, but he tells you, I'm having chest pain. And when I was on the roof, that chest pain made me fall. It made me collapse. And that's how you find him down. Well, he may be in cardiogenic shock. He may be having a heart attack. If he has a heart attack, this artery might be clogged and not feeding that part of the heart. If that part of the heart isn't getting oxygen, it's not going to work as well. The heart is a muscle. So if this part of the muscle isn't working, it's not going to squeeze the blood through the system with enough pressure. That's cardiogenic shock. How do we figure this out? Well, really, we should have blood work. We should have an EKG, all the things you would find in a hospital. But that's not what we're talking about. We're talking about you on the scene, first responding, trying to figure out what's happening. If you ask the patient about his history, he may tell you, well, I had a heart attack 3 years ago, and I'm on medications for my heart, but I don't always take them. And maybe he tells you that he smoked cigarettes. Maybe he tells you that his father or his family has a history of heart problems or heart attack. All of those things help you to think about the person who may be having cardiogenic shock. And on the scene, there's a couple of things you might be able to do. If this patient has a history of cardiac problems and he's having chest pain that's ongoing, you can ask some other questions. Is that chest pain radiating anywhere? Is it radiating to the jaw, to the arm, to the back? Is the patient sweating? Now, on a fire scene with turnout gear, everybody's sweating, right? But you can ask if he's sweating more than usual. As you cool him down, is he still continuing to sweat? Is he having nausea? Is he sick to his stomach? All of these can indicate something going on with the heart itself. If he carries medication such as nitroglycerin, you can give him a nitroglycerin to see if that helps. Nitroglycerin dilates that coronary artery and helps it to get oxygen to the heart. Other than that, the real job for this patient is to get him to a hospital where he can get an EKG, he can get some blood work, and figure out if he's having a heart attack. So that's cardiogenic shock. Let me change up this story a little bit more. What if that patient that you found said to you, well, I was on top of the roof and I kicked up a nest of hornets, and they stung me where I had some exposed skin on my wrists, on my neck, and now I'm having a hard time. And you examine the patient and you find that he has hives on his skin, on his neck, on his chest, on his arms, and he may be even having some difficulty breathing. So how do we think about this? This is somebody who could be having vascular shock or anaphylaxis. And I bring you back to this graph here that we use to talk about volume shock. And this is anaphylaxis, where all of the vessels are vasodilating. they're getting larger. So you have the same amount of blood volume. He's not bleeding, but the relative blood volume is lower. So with all the vessels dilated, he doesn't have enough blood in it to get back to the heart, to prime the pump, to keep the blood pressure up. So it's a very similar picture where the relative blood volume decreases, skin perfusion decreases, the heart rate goes up to compensate, respirations may go up to compensate, and the blood pressure will maintain until it doesn't. So with this problem, it's a very different fix. This patient needs epinephrine. If you have epinephrine and you have a patient with anaphylactic shock, give him the epinephrine. That will constrict the blood vessels and bring you back to adequate volume. Now, the epinephrine doesn't last very long. So after you give the epinephrine, you want to work on getting that patient to a hospital. He may need more epinephrine. He may need more volume. He may need something else. If the patient can take volume, if he can take anything by mouth, you can give him fluid. If you have any antihistamines like Benadryl, you can give him that as well. That helps with the symptoms, but the true fix to this problem is epinephrine. And if anybody has a history of allergies to bee stings, they should be carrying their own epinephrine kit. And you can ask them, do you have epinephrine with you? And they may have it. You can take it out and you can give them the epi. So to review with the circulatory system, you're assessing your patient, you're doing your primary assessment, your secondary assessment, and you're trying to figure out if the circulatory system is in trouble. Is the heart working adequately? Are the blood vessels adequately toned? And is there enough blood volume? Some of these problems you can fix right there. If your patient is bleeding externally, you can put direct pressure that's well aimed and stop the bleed. That can fix somebody who may have gone into circulatory shock or volume shock if you didn't stop the bleed. If it's an internal bleed, you need to get them to a hospital. If they have anaphylaxis or vascular shock, they need epinephrine. If it's a cardiac problem, they may have nitroglycerin. You may be able to give them that to buy some time, but they definitely need to get to the hospital. So these are big system problems. Many of them you won't be able to fix in the field or right where you found them. So let's move on to the next system with a different case. You're now brought this patient. This one in the middle is being brought out to you with his coworkers, and he's having some breathing difficulty. He's been in the building and he's now not able to breathe adequately. So they bring him to you. And here's where we're going to look at the respiratory system. The respiratory system we divide into anatomical structural parts. We've got upper and lower airway. We've got alveoli, which make up the lungs. Then we have the whole chest wall, which is the ribs and the thorax. And then we have the neurodrive, the brain that gives us the drive to breathe. So I want to review AVPU for you first, because it's going to play into how we assess our respiratory patients. Remember, AVPU is a very simple and clear way to describe your patient. If I say my patient is A on the AVPU, that means he's awake. I walk up to him, he starts talking to me, no issues. If I walk up to him and he doesn't start talking to me right away, I may say, hello, hello, can you hear me? And then maybe he opens his eyes to my voice. That's somebody who is V on the AVPU. If he doesn't respond to my voice and I need to pinch him or give him some kind of a painful stimulus, then he wakes up and opens his eyes and starts interacting with me. That's a patient who's responsive to pain only. And if he doesn't even respond to pain, he is completely unresponsive. You can see how A is the best. That's how we all are right now. But as you get into a critical systems problem. The sicker you get, you move down on the scale. So if you're outside at the fire scene and somebody radios to you and says, we've got a patient who's in the building and we're bringing him out to you, he's you on the AVPU. That's a very clear picture of what's coming out. But if they say, our patient's coming out to you, he's A on the AVPU, he's alert and oriented, then you have a completely different picture. But it's a very clear and easy way to describe the patient's mental status. And we use this when we're talking about respiratory problems. When we have somebody with breathing difficulty, we divide it into 3 categories. Remember, everything's got to be simple. The first one is respiratory distress. This is the patient who's having difficulty breathing. They may be able to speak short sentences. They may be tripoding. They may be leaning forward to try to breathe as well as they can. And they're A on the AVPU. Of course, they're anxious. Anybody who is having breathing difficulty is anxious. The next problem that's worse is respiratory failure. This is the person who can only give you 1 or 2 words at a time. They can't even get a whole sentence out without having to take another breath. They may be A, but they're close to becoming V or P on the AVPU. So they're getting worse. That's respiratory failure. Respiratory arrest is when there is no breathing at all. And it's oftentimes associated with circulatory arrest or cardiac arrest. So they are you on the AVPU. So you can see how if you're waiting outside for that patient to come to you and your coworkers say, I'm bringing a patient out to you who's in respiratory failure and he's V on the AVPU, you know what's going on pretty well before you even see the patient. Communication, as you all know, in the world of firefighting is very important because you can't always see or be next to the people that you're working with, and you need to have clear and brief communicating skills to be able to tell people what's going on and to be able to help people. So let's go through the anatomy a little bit. When we talk about the upper airway, it's here, the nasopharynx and the oral pharynx with the big old tongue there. If somebody is in a fire or in a superheated area, maybe they even had a camping stove explode in their face. Any kind of exposure to superheated air can cause burning. We always have to be very vigilant to look for burning. If you have somebody who inhaled superheated air or smoke or fire, you may see soot around their nose. You may see soot around their mouth, but you may need to look into the mouth to look for particles of soot. Some particles, a few particles is concerning. It's never easy to tell how much superheated air somebody inhaled. So we're always very vigilant. So I'm looking for soot, I'm looking for burning, and I'm looking for edema, I'm looking for swollen tissues. If we move to the lower airway, now we're at the larynx, the voice box, and the trachea that leads down to the lungs, and even the big bronchi. If you slice one of these and look at what it looks like in cross-section, it's made up of cartilage, it's got a muscular layer, and then it's got this soft tissue or mucous membrane. When somebody inhales superheated airway or a burn, this tissue swells up. And when it swells up, it swells in. So you're decreasing that lumen or the area that the patient has to breathe through. This is the same thing that happens when somebody has asthma and you hear wheezing. If somebody's got a burned airway, this swelling can be very severe and it can close down the airway. And you may hear wheezing, or you may see that they have a difficult time getting air in and out. The alveoli are what make up the lungs. This is where the exchange happens, oxygen for carbon dioxide. And this kind of a problem, we're not going to really have any immediate fix on people who have pneumonia or infection will have problems with this oxygen and carbon dioxide exchange. If somebody has pulmonary edema, which can happen if you get a burn to the airway, it may put some fluid into the lungs and make it difficult for them to breathe. And finally, we need to talk about chest wall trauma. This can cause a respiratory problem. And I want you to think about the patient who fell or who had an impact or who had something puncture the chest. And let's start with the puncture. This is the chest wall made up of the ribs. Inside, you have lungs, one on each side. The lung is surrounded by what's kind of like a plastic wrap. It's surrounded by a layer that protects it. And if you have, let's say, a stick or an axe or something that penetrates the rib cage, now you have a hole, and air can get into that hole. It's not getting into the lungs except by breathing, but it gets into this hole and it doesn't come back out very easily. So you're creating air and maybe blood that's compressing the lung. This is what a collapsed lung is. This is how that happens. If you have air or blood, that needs to come out. If it compresses enough, it can push on the heart and push on the great vessels and cause the patient to go into a cardiac arrest. But if you have an open hole here, that's good, because now it has some way to get back out if it's under pressure. The way we find this is by examining the patient, and we look for any kind of a wound or a hole in the chest and difficulty breathing. If you have a stethoscope and you can listen to the lungs, you may hear decreased lung sounds on this side. Well, what if there's no hole and you had an impact and the rib fractured and it punctured that surrounding layer around the lung? This is a worst case, because now you've got the air that's building because there's a hole puncturing the lung. Air comes in through breathing and it gets caught in here. Every breath the patient takes puts a little bit more air here, and that lung is collapsed. That's a problem. And you can have simply a flail chest, or two or more ribs are broken and they're impinging, but you don't have lung collapse. So when you think about chest wall trauma, look for the wound on the outside, look for palpation of ribs that are tender or unstable, or they may be fractured, and think about whether or not both lungs are working well enough. So with all of those problems in the respiratory drive, we're assessing our patient and trying to figure out, are they in respiratory distress, or are they in failure, or are they in respiratory arrest? The treatment is different for each. In respiratory distress, that person is still awake enough. We have to try to figure out what's the problem. Did they inhale superheated air? Do they have a burn? Then they need to get to hospital. They need to get to somebody who can put an endotracheal tube in or put an airway in to prevent that burn from closing down the airway. Are they in failure? Then we need to really support them, maybe even breathe for them. If you have a bag valve mask or oxygen, you can give it to them. The position of the patient is very important. Sometimes we always want to lie our patients flat on their back, but in the respiratory patient, they want to sit up. They want to lean forward to maximize the space that they have to expand their lungs. And if they're in respiratory arrest, then we need to breathe for them with positive pressure ventilation in a safe way with a bag valve mask, and get them to somebody who can take care of them. And if they're in respiratory arrest, they're likely going to be in cardiac arrest soon, if not already. So that's the respiratory system. But I'd like to give you another case. This is actually a picture from Baltimore City, where they lost 3 firefighters in this building because it collapsed while they were in there. Again, I just want to stop and say that the work that you do is so incredibly important, and it's very dangerous. And I respect and really value all of you who do this work. So let's say you were outside and your colleagues brought you a patient. They said, we're bringing you a patient who is V on the AVPU, and he was stuck in the building because the stairway collapsed. They're bringing him out to you. Now you're thinking about the central nervous system. And this happens to be my favorite organ, the brain, because it controls all other organs. And in order to talk about the central nervous system or the brain, we need to review AVPU again. Remember, if the patient is awake, they're interacting with you. If you have to talk to them to wake them up, they're V. If they only respond to pain and nothing else, they're P. And if they're U, they're unresponsive. That's different from the AO times 4 or the alert and oriented to scale. If a patient is A, if they're awake on the AVPU, then we're going to try to figure out, well, do they know who they are? What's your name? Do they know where they are? Do they know what time or what day is it? And do they know what happened? And this will be important as we try to figure out the mental status or the condition of the brain with our patient. If your patient is brought out to you and you notice that he's not oriented to person, place, time, or event, now you're worried about, well, what's causing that? And I have an acronym that I love to use, even in the emergency department, to figure out what could be causing this altered mental status. And I go through it. S is for sugar. Do they have low blood sugar or high blood sugar? If they have low blood sugar, you can fix that by just giving them some glucose, and that'll actually fix their mental status quite quickly. Temperature, are they very hot or very cold? That can cause an altered mental status as well. Oxygen, are they lacking oxygen? Have they been in the building too long and they ran out of air and they weren't able to breathe and they're now hypoxic? Pressure refers to intracranial pressure, and we will talk about that. Electricity, ask the question, did they have a seizure? Are they having a seizure? Altitude is something that if you are at altitude on a high mountain, you can have altered mental status simply because of the concentration of oxygen. Toxins, if you're going into a burning building and there's plastic hangers that are burning, that can put off cyanide in the air or other toxins. When things burn, they give off toxins. Toxins can affect the brain. We need to think about that with our patients that are involved in fire. And salt refers to salts like sodium. If somebody is sweating a lot, they are sweating out their sodium. And if they're only replacing it with water, they can develop what we call hyponatremia or low sodium. And they can develop an altered mental status from that. So as you go through this, you're asking all these questions. If you have the ability, you might get a glucose level, a finger stick glucose. You might just ask yourself, do I need to worry about toxins? Was there anything in there burning? What about the salts? Now, if your patient got stuck in the collapsed stairwell and he can't remember what's going on, I'm worried about the brain. If you took him to a hospital and got a CAT scan, you might see one of these pictures. This is a subdural hemorrhage. This is an epidural hemorrhage. This is a hemorrhage or bleed of the brain itself, where these bleeds are around the brain, pushing on the brain. You can see in this one, there's a skull fracture. This is blood in the ventricles. This is blood around the ventricles and around the brain. And this is called diffuse axonal injury, where neurons get stretched and they can bleed. So why do I show you this? I show you this because we will never see on the scene what's going on in the brain. If we had CAT scan, we would see it, but we don't. So we need a different way to figure out if there's something going on with a patient with traumatic brain injury. So think about the skull. It's a hard shell. And inside, there are three things. There's brain, there's blood in the vessels, and there's cerebrospinal fluid. Cerebrospinal fluid is produced in the very middle of the brain, and it bathes the spinal cord and the brain itself. If you have a patient who has one of these bleeds, now you have a bleed that's taking up space. And when it takes up space, it's going to push on the brainstem. And the brainstem is what controls everything. It controls our blood pressure, it controls our breathing, it controls our wakefulness. So that's concerning. As with anything, the bleeding will happen right away, but swelling or edema will happen over time. So in the first 24 hours, all the bleeding will have happened. And actually in the brain, the bleeding pretty much stops because there's such tight quarters in there that it tamponades, it stops itself. But the swelling is what will happen. If that swelling happens, it's going to contribute to the pressure on the brainstem. And this is what we're worried about. So how do we figure this out? Well, somebody gets hit in the head. I want to figure out if they have traumatic brain injury or not. So if they have any change in AVPU, if they're V or P or U, by definition, because they get hit on the head and they have a change in AVPU, they have traumatic brain injury. If they don't have that, but they have any degree of amnesia, they have TBI. And this I've determined by asking them, tell me what happened. If they say, listen, I was going up the stairs and the stairs collapsed and I got caught, I did hit my head, but I didn't pass out. I remember every single thing. And I remember my friends coming in and getting me and dragging me out. There's no amnesia. They remember everything. They don't have TBI. If they have any change in AVPU or any amnesia, I'm calling it TBI. Well, why is that so important? Because now I need to worry if they have traumatic brain injury, they might have a bleed and they might have increasing ICP, and that can kill them. So how do we notice if somebody has increasing ICP? The first step is, do they have TBI? If they don't have TBI, they hit their head and I'm going to worry about the rest of the systems. But if they do, I'm going to watch for increasing ICP. And this is how I see it. Early on, they'll have mental status changes. So they may get irritable, they may get angry, they may be anxious. They're going to have a severe headache. And they may have persistent vomiting. Anybody who you see who hit their head and has mental status changes or a severe headache or persistent vomiting, they have increasing ICP until proven otherwise, and they need to move quickly toward a hospital. Late signs are when they start dropping on the AVPU, when they're V or P or U. Now we know there's a lot of pressure on that brainstem. If you see seizures or posturing or a dilated pupil, that is worrisome. They have less time than anybody. And we look for vital sign changes. These vital signs are different from the volume shock. In this patient, you'll see an increase in blood pressure and you'll see a decrease in heart rate. The brain is trying to protect itself by keeping the blood vessels open and decreasing the heart rate so it's not pumping more blood in there. As for the respiratory, they will have irregular respirations, and it depends on which part of the brainstem is injured. So, just to recap, if I see a patient who got hit in the head and has traumatic brain injury, I'm watching for any of these signs. What do I do for that patient? I'm not at the hospital. I'm with him right now at the fire scene. If I have oxygenation, I'm going to give it. I'm going to try to keep his head a little bit elevated. We know that if the head is elevated instead of lying flat, then it helps blood come out of the brain through the vessels and keep it out of the brain to decrease that swelling. I'm going to treat pain if I can. The patient is awake enough to take some pain medication, I will give it. I, of course, want to evacuate this patient and get him to a higher level of care. I'm going to anticipate vomiting. Remember, the patient who has TBI, has increasing ICP, will vomit. So when I transport that patient, I might be transporting him on his side so that if he vomits, it won't go back down into the airway. And I'm going to watch that neuroexam. How do I watch the neuroexam? By talking to the patient. One person is assigned to that patient, talks to him the entire way to monitor where he's going, as well as give him reassurance. Anticipate hypothermia with all of your critically ill patients. Remember, if they're critically ill, they're not able to generate their own heat. Even if they just came out of a superheated area, you're taking off their turnout gear, you're exposing them to the air. Even if it's not cold, they're not generating their own heat. They will be colder than you are. Just know that. And maintaining blood pressure is important if you can. If you have any way of getting an IV and some IV fluid, or if they're able to take any fluid, that's important as well. So just to review, we looked at the primary assessment. We looked at the circulatory, the respiratory, and the nervous systems. We realize that in the circulatory system, we have to look for bleeding externally, internally, recognize it, look for the vital signs, determine how fast we need to get that patient out. With respiratory, have those patients in the right position. Sitting up may be best for them. Give them oxygen if possible. If they stop breathing, we're going to use positive pressure ventilation. And with the nervous system, understand what makes a traumatic brain injury, how to recognize that, how to get those patients to a higher level of care. What we didn't talk about is the spine. And anybody who has a traumatic injury, trauma to the chest, to the head, you want to assess the spine. And you do that by palpating, and I'm sure Paul talked about this with you last week. Palpate the spine, look for step-offs, and make sure that they can move both hands, both feet, and that the signal's going through the nervous system. And those patients need to be transported safely without moving their spine as much as possible. So with that, I once again thank you for your service and thank you for being here. And I'd love to take any questions that you have.
All right, thank you so much. What a great presentation, packed full of good information. And we'll get you to send me a copy of that presentation if you don't mind, and we'll post that in that Google Drive folder that I posted earlier. There'll be a link where you can rewatch the video. And there's also a folder in there that says extra training materials or something to that effect. So you guys will be able to find that presentation there and review that. We'll move on to some questions. I'm sure there's got to be some questions out there. If you have a question, feel free to unmute yourself and ask a question. Click the raise hand, place your question in the chat, and we will get it answered for you.
While we're waiting for questions, can I say I'm very excited to see some women firefighters in the group here.
We've got a number of firefighters, and we also have some EMS personnel that work with Red Cross and things like that join us as well.
That's fantastic.
Might I ask something?
Go ahead.
What are the legal parameters around taking care of a patient, if that's a liable question?
So the legal parameters, it depends on what your role is. If you are a bystander, if you just happen to be walking along and you stop to take care of a patient, you are operating as a volunteer. You're operating as, just a bystander. You don't have a specific role. If you are on a roster, if you're on duty and working as an EMS person or a firefighter, then you have a role and you are expected to take care of that patient. And the standard of care that you would be held to is somebody who has similar training that you have. And I would welcome anybody from the continent to tell me if it's different. What I'm speaking to is really what we have here in the United States is if we are on duty, we're expected to work at the standard of care, somebody who's trained similarly and with
Thank
the
you.
equipment that you have. Yeah.
I see, Timmy, you've got your hand up. Go ahead.
Yes, how are you, everyone?
Very good, very good. Thanks for joining us.
So my question is, for the TBI patient, which painkiller do you prefer we should give to the patient?
Is that with the TBI patient you asked?
Yes, which painkiller do you prefer we give the patient? Because if we tend to give aspirin, which is the most painkiller that we tend to use, aspirin is a blood thinner, so it might increase the blood inside the patient's head. So which painkiller would you prefer we give to the patient?
That's a great question. I'm glad you asked it. Yes, aspirin would not be preferred. I would use acetaminophen, or if you have somebody who has ALS and has IV and they can give morphine or one of the morphine or fentanyl or one of the opiates, that's the best. But recognizing that you may not have an IV or access to those medications, I would choose acetaminophen.
Sorry, what is the other name for acetaminophen? The trade name for acetaminophen.
Oh, it's Tylenol.
Daniel, I see you've got your hand up. Go ahead, sir.
Yes, I would like to answer the previous question about the standard.
Yes, please, go ahead, sir.
Yeah, surely standard of operation applies to each and every country. We operate within the scope of practice. And also when we are giving those medication, it also matters. Are you allowed to give them, or what do you do in such times? And the best bet is recognize and quick evacuation. You expedite transport as early as possible to definitive care facility.
Thank you, Daniel. Anyone else have any other questions as we get ready to wrap up the formal part of our training here?
Just one more.
Go ahead, sir.
What would be the procedure for someone who's in hemophilia, I think it's called? Someone who can't blood clots on their own.
Are you talking about somebody who cannot clot their blood?
Yes.
Yeah, that's a particular problem. They are either typically missing something called factor 8 or factor 9. And what they will need is an infusion of those factors in the blood. So in the immediate time when you find them as a first responder, it is the exact same treatment, direct pressure, well aimed for external bleeding, and with any suggestion or concern for internal bleeding, they also need to be, they need to get to a hospital, figure out what's bleeding, and either surgically fix that or to get the factors on board. So I wouldn't treat them any differently than I would somebody who doesn't have that, because you can't get factor 8 in the field. You can't really get that to them need to figure this out. The best thing for volume shock patients is to keep them supine, lying flat, because you don't want to increase the rate of the bleed internally if that's going on, making sure there's no external bleeding. Give them fluid if possible, and that could be either by mouth or it could be by IV, or I don't know if you have access to something called dermoclysis, which is sometimes used in disaster areas where there's some very fine needles, very, very small needles that you just put onto the skin. It goes into the subcutaneous, and it very slowly releases fluid into the subcutaneous tissue that is then absorbed into the vasculature. This is used with veterinary medicine with animals sometimes, but it's mostly used in disaster areas. So if they can get fluid somehow, that's good. Keeping them supine, monitoring their vital signs, monitoring their mental status, and quickly getting them to a center that can evaluate, do some blood work and figure out if they have those factors missing and if there's something bleeding internally.
Thank you.
We'll take one last question there. Samson, I see you have your hand up. We'll take one last question for the formal part of the training, but stick around. We do have more that we're going to address here. Go ahead, Samson.
Good afternoon.
Hello, sir.
I really appreciate this lecture. Honestly, I'm really impressed. My knowledge has been broadened. Now, I need to just understand because, you know, here, what we do is we do not mingle things together. We have paramedics that go along with us. We have to go to fight fire. Persons like me, I just know how to kill the fire. All these that has been discussed, said, that's added to my knowledge. But I want to understand, in a situation like this, where I don't even know the A from the B of a victim, and it happens that the paramedics are not available, can I begin to apply this professionally when we are in the fire scene? Will it be appropriate?
My answer to that question would be absolutely yes. And the best thing to do, and if I understand you correctly, you're saying, well, I'm a firefighter. My job is to put out the fire. I just might happen to come across a patient who's injured. The best thing you can do is to recognize that and start doing the assessment. That scene safety is so important. So many people get injured because they don't look at scene safety and they run in and they try to take care of the patient and then they get injured themselves. Watching for scene safety of your colleagues and then doing that primary assessment, figuring out what you think is going on and communicating that to the paramedics who might be outside the building, who might be on their way, who might be somewhere else, and having that communication. It's a lot to take in, understanding all of the medical issues, but if you start with the basics and can at least understand the basics and communicate that, you are bringing this patient a long way toward help.
Excellent. Yep. And just really anything you can do there to get that airway open, to try to get them breathing again, and to stop any uncontrolled bleeding. As a lay person with no training, those are all things that you can all do and will really reap benefits for that person while we're waiting for that medical care. We're waiting to arrange for a bystander to help us transport that person to the hospital if that's what we have to do. At this time, I want to thank Dr. Evie. That was an awesome presentation. I know myself, I'm going to go back and probably watch it one more time while I'm editing, just to refresh myself on some of that stuff. It was really great, packed full of good information. Encourage everyone to review this again, to go back and look at last week's training. Those two really work well together. What a great team to have there. Thank you so much. AFM is very appreciative of you guys giving your time to come and do that training for us. And appreciative of everyone else for attending for today. Please be sure to join us again next week, share it with your fellow firefighters, share the registration link, and we'll see you all again next week.